Okay, so I think we'll make a start, guys. So I'd like to welcome everyone to our first ASH webinar for 2024. My name is Philip, and I'm the Education Officer for the Haematology Society. And we're really excited to present to you all a very high yield and important topic of hematological emergencies as our first educational webinar for the year. So to begin, I'd like to do an acknowledgement of country. I acknowledge the traditional custodians of the land on which we're meeting on today and pay my respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islander peoples here today as well. As an introduction to the Haematology Society, our goal is to spread passion and interest in hematology to keen medical students in a very interesting field that unfortunately might not get as much love throughout med school lectures, tutorials, and teachings as other specialties. But that's why we are here to try to bring that passion to you guys through these webinars and other activities, events, and posts that we'll be running throughout the year. So our plan as a society is to have regular webinars. So we strongly encourage you guys to sign up and join our Haematology Society club through the sign up sheet, which I'm going to put in the Zoom chat now. And also for attendance purposes, if you guys would all be able to fill in the Google Doc, that would be amazing. And that's also because at the end of our webinar presentation, we'll be doing a lucky spin the wheel, where we'll be giving away two $25 gift vouchers to the lucky winners. But in order to be eligible to join the spin the wheel, you will just need to fill in the attendance sheet. So I will send that through in the group chat. Please let me know if you guys can see that. And if you can, yeah, probably best to just fill that in before we get started. So I'm now very excited to introduce our speaker for today, who is going to be Dr. Sean Harrop. He is a hematologist and the current clinical lymphoma lead at the Peter MacCallum Cancer Centre. If you have any questions throughout the webinar, please do put them in the Zoom chat and Dr. Harrop will be able to get back to you to address them. At the end of the webinar, we'll be doing a dedicated 5-minute Q&A as well, where you can ask Dr. Harrop any questions about the presentation or hematology as a field in general. And just a reminder to stick around until the end for the spin the wheel for two $25 gift vouchers as well, which I know us as medical students are very keen to win. So I'd love to hand it over now to Dr. Harrop to introduce himself and to begin the webinar. Thank you.
Thanks, Philippe. So I'm Sean Harrop. I'm a clinical hematologist at the Peter MacCallum and the current lymphoma fellow at the Peter Mac. The lymphoma lead's my boss. Can you guys see my slides?
Yes, that's all good.
Yeah, excellent. So I was asked to say a little bit about myself. So I took a pretty routine pathway in doing BPT locally at St. Vincent's, and then doing most of my hematology training through the Peter Mac in Royal Melbourne, including 2 laboratory years at the Royal Melbourne. More and more people are sort of choosing 3 years over the combined training, but I think the combined training still has a lot of merit. So I think we'll kick off the slides now, and I was asked to speak about hematological emergencies, and there's a few classic emergencies that I guess are important to know about in hematology, and most of them happen inside hematology patients, but not always. And there's also a few sort of newer ones that we're inflicting upon patients with some of the newer drugs we're dispensing. I'd just like to thank Caitlin as well for quite a few of the slides she's provided. Those slides are the uglier ones because I had to remove the Alfred logo she had on them and put the Peter Mac one on. It'd be good if it could be a little bit interactive, mainly because I'm beginning to lose my voice. So we'll try and do a bit of a case discussion as we go and make it a little bit more interactive as we go. So So the first case to start with is a patient, it's a known to haematology, that has just spiked a temperature of 38 degrees and come in as directed by the haematologist on call. Would anyone like to sort of volunteer some things that would be really, really critical to know about in this patient?
I think it would be good to know if they are a known hematology patient, what condition they've got, what treatments they've had, and if they've got any particular localizing symptoms that could indicate where like a potential fever could be coming from.
Yep, that's all very important. So for argument's sake, this patient has large cell lymphoma. Yeah, I'm seeing FBE come up a lot. So yes, yeah. So a full blood examination, in particular, a neutrophil count would be very would be the single most important thing to know about in this patient. So this is a 70-year-old gentleman he's known to have DLBCL or diffuse large B-cell lymphoma, which is the most common aggressive lymphoma. And he last had chemo 7 days ago, which is very important to know. And he comes in with those observations. So temperature of 38, he's hypotensive 91, he's tachycardic 144, his oxygen levels are okay, and his respiratory rate's not too bad. Before I go to the next slide, any different differentials in this patient for having a fever? I might have jumped ahead too quickly, but you can please feel free to shout out. You don't have to hide behind the typing. You can.
Just a febrile neutropenia.
Yeah, so I'm going to rephrase that as infection, because if he's neutropenic and he's febrile, he's febrile neutropenia by definition. But infection is definitely something that would be very important to know about. Any other causes of fever in this patient cohort?
Maybe a tumor lysis response?
That doesn't tend to cause a fever in itself. But good thought. Good thought. So I saw iatrogenic come up. Did you want to expand on that by exactly what iatrogenic, what you mean? Yeah. So I might just move on. So infection is sort of what we think about in these patients. The other less common sort of causes, and you basically presume this gentleman has an infection, but the other things that could be important to think about are things like cytokine release syndrome. So that's a syndrome that I'll get to in a little bit later, but it's basically related to some of the newer drugs we use, and we're seeing it more and more often as we use some of the newer drugs more often. Disease is really important to know about. So a lot of people with large cell lymphoma will have fevers related to their disease. And that can sometimes be sort of concerning for relapsing or refractory disease, even halfway through chemotherapy. The other thing, and this is probably the least common of all, is certain types of chemotherapeutic agents can cause fever in themselves. So cytarabine is probably the most classic one, and that can often be a bit problematic during AML induction when you're having patients that are having fevers and they're neutropenic, and you're treating these people as infection, but it's probably the cytarabine, and once the cytarabine stops, the fevers tend to go away. So we know with febrile neutropenia, the definition is an absolute neutrophil count of either less than 0.5 or less than 1 and expected to drop further. So the mortality rate is sort of between 4 and 30%. So 1 in 3, up to 1 in 3 patients can die. And this is from Australian data. Those at risk, obviously, are patients on chemotherapy or those with neutropenia secondary to their conditions. So things like AML and myelodysplastic disorders can cause low white cell counts. The causes of the fever, the most common are bacterial, but then viral, fungal, PJP, and then drugs as well are causes of the fever. The most common cause of fever in febrile neutropenic patients is just gut translocation. So we've got lots of bugs in our gut. They're normally kept there by our gut being lined with intact mucosa, and our immune system keeps it all in check. And chemotherapy obviously sheds the gut, gets rid of the immune system, and all those bugs, which is apparently kilos of microbes, can get into our bloodstream and cause sepsis. Interestingly enough, though, we often don't find any sort of positive blood cultures in patients with febrile neutropenia. And I'm not quite sure that's well understood, because we certainly do a lot of cultures. So what to do in someone with febrile neutropenia? So the first person to see these patients is obviously emergency, but hopefully they would assess the patient clinically. They would assess for infection at all the common sites, so chest, gut. They would look at the lines. So often these patients have semi-permanent lines in, or PICC lines, or ports that have been put in for chemotherapy. They look at the mouth for mucosal membranes. Often all these things are normal because, like I said, it's often just gut translocation, and they don't really have any focus. The other thing about these patients is because they have no neutrophils, they often don't form things like abscesses, and that would be symptomatic. So that's often why once a neutrophil comes back, they'll often develop symptoms at a spot of infection, because that's that immune reconstitution. After doing, I guess, the basic septic screen, which is blood cultures, chest X-ray, urine, all those things, you would start antibiotics at that point. So that's broad spectrum antibiotics. The covering Pseudomonas is probably the most important thing. So something like tazocin. And generally, you'd start GCSF in these patients as well, or fulgrastim, to try and improve that neutrophil count. There's no data that shows that fulgrastim is associated with improved survival, but it does shorten the period of febrile neutropenia. The other important thing is if people have persistent fevers and they're not really improving with antibacterial therapy alone, keeping in mind that a cohort of these patients are at risk of fungal infections. So looking for that with sort of high resolution CT of chest and sinuses is important. Also, before starting antibiotics, which is generally tazocin, just checking previous microbiology to make sure they've had nothing like ESBL, which would require meropenem, because these organisms tend to be resistant to tazocin in particular. So this is what I would like to hear from emergency when they call me up. Often that's not the case. I'd be lucky to get half this. But I would like to know how old they are. I'd like to know what day they are, of what chemotherapy regimen they're on. I'd like to know if they're an inpatient, what infective issues they've had so far, as well as their previous microbiology, in particular those resistant organisms that would mandate a change in antibiotics. I'd like to know if they're on any antibiotics at the moment and how long they've been on them for, and importantly, whether they have a line or not, because a line is a very common source of infection that often need to be removed before antibiotics can really be effective. And this graph just highlights that GCSF, despite being pretty good at shortening the duration of neutropenia, most patients still become neutropenic between day 8 and 12, despite GCSF. So it only really shortens the duration of neutropenia by sort of 4 to 5 days. So it's important to sort of note that despite these patients being on GCSF, they will often still be neutropenic for almost a week. And these are just the guidelines. So a lot of those authors there are sort of Sydney and Melbourne. Con, I think, works at the Alfred at the moment. And he wrote this sort of 10, 15 years ago now, and not much has changed. So it's a pretty good article to look up, and it's just talks about the rationale of different antibiotics and why they're utilized. So next case, so you're the medical intern on take for the day, and ED refer a patient, 59-year-old man, for admission. He's presented with back pain and feeling generally unwell. Being ED, they haven't ordered any blood, so as the medical intern, you go and order those bloods, and this is what you see. Does anyone want to call out, I guess, any particularly worrying results and why they would be worrying in a gentleman presenting with back pain?
It looks like his calcium's pretty high. And so in a gentleman with back pain, thinking about multiple myeloma as a possible differential.
Yeah, I mean that's it in one. So I think this is myeloma until proven otherwise. The other sort of things that are suggestive of that is his hemoglobins. Can you guys see my pointer?
Yes, we can.
Yeah. So his hemoglobin's low, so he's anemic. He's got a creatinine of 167, so he's clearly got impaired renal function. And his, obviously, as you mentioned, his calcium is up. The other thing, and I sort of cruelly left it out on this plot, but the other thing that can be really suggestive of myeloma is what we call a protein gap. So a protein gap, for those that aren't aware, it's the gap between total protein, or here, and albumin. And so your total protein should be around the numbers of 70 grams per liter. And what the protein gap is, the gap between the albumin and the total protein, and that's normally your other proteins, and most of those would be immunoglobulins, not all of them. But if you've got a very high protein gap, that suggests that there is an abnormality in there, and that abnormality in this gentleman is most likely going to be the monoclonal protein. Obviously, we don't know that without doing serum protein electrophoresis, but it can be very suggestive in someone who's got bloods that would be otherwise compatible with a diagnosis of myeloma. So this is his serum protein electrophoresis. So he's got a power protein of 30 grams per liter. These are his immunoglobulin level breakdowns. So we can see here it's almost certainly going to be an IgG power protein at 39 grams. This is total IgG. So he's still got 9 grams of normal IgG, but his power protein is 30. Free light change you can't see there, but that would be elevated as well. And you can see here his MRI, he's got this nice normal spinal cord right till here, where there's obviously a bit of a plasmacytoma here that's pushing on his spinal cord. So this is a very worrying MRI. So this guy is sort of imminently paraplegic. Looking at that, I'm not a radiologist, but it's almost completely effaced his spinal cord. So this is an emergency. So this needs to be sort of addressed same day, and we would obtain urgent neurosurgical and radiation oncology opinion. So the surgeons probably won't want to touch this. There's very few times that go in on a hematological tumor. And that's normally because hematological tumors like myeloma, lymphoma, they're quite steroid sensitive, meaning that it will probably shrink down to a reasonable degree for at least a few days with steroid therapy alone. And they're mostly, almost always radiosensitive. So lymphoma and myeloma, they sort of melt away with radiotherapy. Things like lung cancer and breast cancer obviously don't. So the neurosurgeons would want to cut those out because radiation oncology is going to take too long to work. But blood tumors tend to just dissolve with radiotherapy. So the surgeons will tend to prefer the radiation oncology approach. So just to remind everyone, so it's also one of the few times the radiation oncologist will come in on the weekend. So it is a true sort of emergency. Just to remind everyone that myeloma is an increased clonal plasma cell in the bone marrow, so at least 10%. There's most often, but not always, a paraprotein in the blood by definition. And then the old definition was CRAB, so hypercalcemia, renal impairment, anemia, and bone lesions. There's this new, newish definition, slim CRAB, which is sort of light chain ratio MRI lesions, which can be used to diagnose myeloma a little bit earlier than we previously could. So this is the third case. So you're the night shift resident on for the night, and you've just been woken up by one of the nursing staff who have alerted you to the fact that the laboratory has called them and about some biochemistry results. And you open up Epic or whatever your EMR is at your hospital, and you look at these biochemistry results, and you've been told it's a hematology patient because you're covering hematology. What do you think? Does anyone want to throw out any suggestions about what they think is going on here?
It could be hemolysis because there's increased lactate dehydrogenase and increased bilirubin.
Yeah, no, certainly. I mean, it certainly could be hemolysis. That's a very good point. What else though? That would, I guess, I think that the bilirubin's a bit misleading because this guy was very unwell. But what else could it be? Keeping in mind it's a hematology patient.
Like an active hematological condition relapse because of LDH increasing?
Yes, yep. So LDH is a good marker of cellular division and breakdown. And
Or
yes, yes. So this guy, yes, he definitely has a sort of a very fast-growing hematological problem. And this was a 48-year-old man with probable high-grade lymphoma. And sort of you go through the notes and you realize he was admitted to hospital yesterday evening, a few hours ago, and these are just his bloods coming back for the day. And he hasn't started any chemo yet, and his normal creatinine from a few months ago was 90. So this was his PET scan. This was his PET scan after 3 months of treatment. Anyone want to throw out a diagnosis for what they think this could be? There's a few options. I think one's probably more likely than the others. Just given that sort of amount of tumor lysis and that PET scan image. Yeah, I just saw Burkett's in the chat. Yeah, so but this is, if I saw that PET scan and I saw that blood results, I would be reasonably confident it would be Burkett's. There are other types of high-grade B-cell lymphoma that may sometimes be this bad, but 9 out of 10 times it's going to be a Burkett's lymphoma. So tumor lysis syndrome is a sort of a group of metabolic abnormalities that sort of group together, and it's really due to sort of cancer cell death. They just release their toxic amounts of their intracellular contents into the circulation. Importantly, it can occur spontaneously or post-treatment. Spontaneously tends to be sort of very high grade, very fast growing lymphomas like Burkett's, while post-treatment, obviously Burkett's post-treatment will do it as well. But even indolent lymphomas, if you kill them fast enough, can cause tumor lysis. So things like CLL or SLL, when one of the drugs we used, venetoclax, first came out, one of the problems that we ran into early on was that it was much more effective than we ever thought it could be, and that we were getting tumor lysis, which was actually amazing at the time. It was before my time, but it was amazing back then because we hadn't really seen tumor lysis before in SLL or CLL because nothing could kill it that quickly. So that I goes to demonstrate that even slow-growing lymphomas, if you kill them fast enough, will demonstrate tumor lysis. The risk factors are sort of people with pre-existing renal impairment and dehydration, because remember, these toxic contents just have to be flushed out by the kidneys. So if your kidneys aren't working as well to begin with, you're at higher risk of developing it. And some of the dangers with tumor lysis are things like developing renal failure, arrhythmias, seizures, tetany, and all these things can obviously lead to cardiac arrest and death. This is just basically the same sort of saying the same thing, but in pictorial form. So you've got your tumor type. So Burkitt's is probably the most high risk, but certain types of lymphomas or acute lymphoblastic leukemias are all high risk. Your things like adenocarcinoma are very low risk because, unfortunately, chemotherapy can never kill them quick enough. Tumor breaks down, you've got breakdown of cellular DNA. That DNA obviously releases all the nucleotides. Those nucleotides are then broken down further into uric acid. You become hyperuricemic, and then they precipitate in the kidney and cause kidney failure. So there's two sort of ways to, I guess, assess tumor lysis. There's the laboratory tumor lysis, which is when we are just checking on blood tests. And the definition is 2 or more parameters that meet those criteria. So a uric acid above that, a potassium above that, a phosphate above that, hypocalcemia, so calcium lower than that, or 25% change within 3 days. So those are all criteria to fit laboratory tumor lysis. Clinical tumor lysis is when any of those things happen, plus either a seizure, arrhythmia, or acute kidney injury. LDH is not on that list, but it's often will go up when you see tumor lysis because it's a surrogate marker for tumor bulk and rapid cell turnover. And if you do see it sort of increasing, it can be a risk of sort of allude to the risk of tumor lysis happening. The biochemical marker we tend to see go up first is phosphate, and then the others kind of follow. So management can be done expectantly, meaning that we do it before we run into problems, or it can be done in response. We try and do it before we run into problems because we don't like problems, and that can be something as simple as IV saline and allopurinol. So most of our patients who are treated with lymphoma will get started on allopurinol. Respirocase is sort of an intravenous drug, which we'll get to in a sec. The points 3, 4, and 5 are more if you run into problems. So that managing the hyperkalemia, managing the hypocalcemia, and managing the phosphate. I can only think of one time I've given a phosphate binder. It's not that common. And CRRT is just dialysis or hemofiltration. And that may be a handful of times, although there was a patient on the ward at the moment. So this is just to remind everyone that allopurinol acts at a different point of respirocase. Case 4. So you are the medical registrar on take, and ED refer a 24-year-old female with bruising and fevers. So those are the FBE indices. Does anyone, and this could be a few things. So there's no definite right answer to this set of parameters, but does anyone want to throw out a few things that they would be worried about or concerned about for this case? Oh, so I just saw a question from in the chat. So how long does it normally take for the syndrome to develop? So it can be very quick. So it can be a few hours, or it can be the next day. It really depends on the treatment and the condition. So Burkitt's, often they'll come in with tumor lysis. something like COL or venetoclax could be pretty quick. But if you were to give another treatment like a obinutuzumab, it could be the next day where you see that tumor lysis. Some drugs are also escalated. So because of the risk of tumor lysis, we start with low dose and then slowly increase the dose. So the tumor lysis presumably would be lower risk early on, but that might increase with dose escalation. Although the reason we dose escalate like that is because we want to try and reduce that risk as much as possible by starting at a low dose. So anyone want to shout out some answers for this FPE? Yes, yep. So APML, definitely could be APML. Any other suggestions? AOL, yep. AOL could definitely be AOL. Looking at this myself, I would. So I guess my approach to this would, I see a young person, and I see pancytopenia. So the things I would think of are before just going on these parameters and no other information at all. Is I think could this be an aggressive malignancy like an acute leukemia, or could this be something like bone marrow failure like an aplastic anemia? The test for that would be a blood film and bone marrow, but we don't have that. So that'd be the two things I would think of, and the two things that I would worry about. Obviously, acute leukemia is something that would be a bit more worrying, but ultimately they're both going to bone marrow the next day. They're both going to get a blood film to assess for blasts. So that would be, I guess, my general approach. It could be lots of things. It could be it could be many things. But if I get a call about this at 2:00 in the morning, bone marrow failure or acute leukemia would be the two things that I would think of, and favouring acute leukemia just because, at least in our population, it's much more prevalent. So that's what we.
Sean, I think we might have lost you, or maybe it's just on my end, but I don't think I can hear you at this stage.
No, I lost him too.
Okay, thanks.
Can you guys hear me?
Yeah, we can hear you now.
Yeah,
Just lost you a second ago. Sean, I don't think we're able to hear you at the moment.
Can you guys hear me now?
Yeah, that's all good. We can hear you now. Uh, are you able to hear us, Sean? Yeah, no worries. All right, we'll give Sean just a second to sort out his technical difficulties. So bear with us for those in the audience.
Can you guys hear me now?
Yep, that's good.
Okay, let me know if it cuts out, because it's I had to disconnect the camera. So does anyone want to volunteer what they think this blood film represents? Yep, so I see AML. Why do you say AML?
The error rods in one of the cell there.
One of the cells?
The error rods.
Yep. No, there's definitely arrow rods. I was just when you said one, is can you see these ones? Yeah. So for those of you yeah, and Naz is right. Although we try not use that name anymore in the laboratory. So those cells are these ones here, and here. For sort of honors, does anyone know what this is? So that's a myelocyte. So these are all blasts, and these two guys are probably myelocytes. So that is immature neutrophils that have progressed past the blast phase, but not quite, well, a long way from becoming a neutrophil yet. So for anyone with so just going back to this, does anyone want to come down on a very definitive diagnosis for this case? Because I would look at this and there was nothing else this could be except this condition. I think someone mentioned it before. Yes, yeah, APML. So the arrow rods, the way they bundle together like that, is diagnostic of APML. So you'll see arrow rods in conditions like AML, but the way there's so many of them and the fact they bundle together like sticks is this is APML. This is there was nothing else that this could be. And for first class honors, anyone know the translocation that you see in APML? I'm not expecting anyone to know. Most residents wouldn't know. Yeah, so it's PML-RR. So PML-RR it's a 1517 translocation, and RR is retinoic acid receptor, and that's a vitamin A receptor. So we treat these guys with vitamin A. So for anyone with suspected acute leukemia, you need to send a clotting screen, and that needs to include a fibrinogen. So not all hospitals will do a fibrinogen as their as part of their regular or routine clotting screen, so or coagulation test. Often they'll sometimes just do an INR and an APTT, but you need to make sure you have a fibrinogen, because fibrinogen is the most important factor. You guys still hear me? Yep. So
Yeah, we can.
Yep. Fibrinogen is the most important factor when in the clotting cascade. Without fibrinogen, nothing else happens. And hyperfibrinogenemia leads to much more severe bleeding than a deficiency in any of the other clotting cascade. So this patient needs to see a hematologist that night, and their DIC needs to be managed almost more importantly than anything else. So their fibrinogen needs to be kept above 1.5 with either cryoprecipitate or concentrate. Their platelets need to be kept above 50, and they need to be monitored very closely for bleeding, because these patients die of bleeding. The outcomes for APML are excellent if you live the first sort of few weeks, and the patients that die in the first few weeks die from bleeding. So the DIC needs to be managed as a priority. And then specific treatment with ATRA, which is just transretinoic acid, and steroids need to be instituted. There's further treatment that starts a little bit later, but I think that's the urgent treatment that needs to start that night to save their lives. So just speaking more generally about DIC, so it's a systemic pathological process. It's a I guess a bit of an umbrella term for quite a few different disorders that all affect the coagulation cascade. And it's a dynamic and sort of generalized activation of the clotting system, followed by activation of the fibrinolytic system. And the pathway is activated by various different mediators of both the intrinsic and extrinsic systems. So some of the causes, and the most common ones of ASSH are major surgery, burns, septic shock, infection, disseminated malignancy, obstetric conditions such as amniotic fluid embolism, severe preeclampsia, snake venom, which I've seen. The most severe case of DIC I've ever seen was a snake bite. Severe pancreatitis, things like a fat embolism after an orthopedic injury can all cause severe DIC. DIC we generally divide into an acute versus chronic state. And the chronic often means it's compensated, so the activation process occurs more slowly. And there's often an excess of procoagulants produced. So these patients often present with thrombosis. And the bleeding isn't as clinically evident, as that the liver compensates quite well. And the bone marrow can compensate by maintaining platelet counts. Therefore, the clinical presentation is mainly via thrombotic manifestations such as deep vein thrombosis. The chronic DIC is more commonly seen in solid organ malignancy, whereas acute decompensated DIC is DIC that occurs very rapidly, and it's dominated by intravascular coagulation. And these patients present, they just bleed and bleed and bleed, and this is what we see in APML. So the diagnosis of DIC it requires a triad of a correct clinical setting, bleeding or other sequelae of DIC, and then laboratory evidence of DIC. So decreased fibrinogen levels, so it's very unlikely to have DIC with a normal fibrinogen. Increased thrombin time, low platelet levels, disordered coagulation cascade, such as an increased INR, increased APTT. There's a calculator. So the International Society of Thrombosis and Hemostasis have a tool to use, and you just basically plot on these things. It's not perfect, so you can imagine most liver failure patients would probably score quite highly. So often it's up to sort of clinical acumen as well to determine sort of, is this DIC or is this something else going on? The management is treat the underlying cause. So DIC is one of those things that will just keep on getting worse and worse and worse unless you remove the underlying cause. We can support patients if the underlying cause is going to take a little bit longer to remove than some. So patients that are on chemotherapies, for example, that have a GI malignancy, in which case chemotherapy is not going to work overnight. We can replace products, including platelets and fibrinogen and clotting factors. that's often only when they're sort of bleeding or at critical levels. There's no evidence to support routine replacement to keep them at any sort of specific level. We certainly would treat if there was any serious bleeding, or if they needed any procedures, or the platelets were sort of below a certain threshold, or there was a high risk of bleeding. Okay, so just going back to the APML case. So this guy was started on Atra, and he was doing really well. His neutrophil count was had, well, more or less normalized, and he had been feeling better. And then you are called to the ward because the nurse has noticed his oxygen saturation had dropped to 80, and a met call is then pretty quickly called, and that's his chest X-ray. Does anyone want to hazard a guess about what they think could be going on? Or maybe we'll start. What do you see on the chest X-ray? Yes, oh, got it in one. So yes, this is leukostasis. So do you know why you get leukostasis? Why this person has got leukostasis? Any so yes, I agree. This is definitely leukostasis. Oh, sorry, you had replied. I hadn't scrolled down. Yes, differentiation. Yes, so this is differentiation syndrome triggered by the ATRA. So differentiation syndrome occurs in patients with acute AML. It's ATRA syndrome. That slide's actually a bit outdated. Different types of AML now with the newer drugs can have differentiation syndrome. It's often a complication of the initial treatment. So it's the differentiation of the blast. So you remember the APML blast is sort of stuck. They're behind a there's a handbrake on them that's stopping them from growing up into normal neutrophils. The ATRA takes that handbrake off, and basically there's all this build up like on a freeway, and that all have to flow through, and they all differentiate or become sort of more mature cells very quickly. Too quickly, and then you get leukostasis because you've just got too many white cells in the bloodstream. They're all flooded out from the bone marrow, and they are blocking the vessels in the brain and the lungs, so people can become confused if they've got sort of cerebral leukostasis. It can block up with pulmonary vasculature, leading to sort of that kind of chest X-ray. So it often occurs 7 to 12 days post-treatment. About a quarter of patients will experience it. We start most patients, or all patients, on prednisolone with the ATRA at the same time to try and reduce this from happening. Despite this, it can still happen. If it does happen, we can give dexamethasone or even pause the ATRA for a brief period of time. The mortality is untreated up to 30%, but dexamethasone can bring that down to 5%. So I think this is my final case. So this is a 17-year-old male NED who presents with expressive dysphasia and upper limb weakness, so a left MCA syndrome. They were referred to stroke, and a CT brain was performed. The stroke registrar was about to perform thrombolysis. However, these blood results came through. Does anyone want to comment on those blood results and why they would, or I guess why the stroke registrar no longer wants to thrombolyse? Anything standing out?
I'm not entirely sure, but is it because considering that the platelet is extremely low, they might have ITP at the moment, and that could increase the ferritin as well?
Yes, yep. No, so ITP is a very good thought. ITP certainly would be one of the things I would think of if that platelet level was that low. So this guy's 17 and he's pretty healthy. What other parameter on the FBE is a little bit unusual and wouldn't be in keeping with ITP? Yeah, yep. So it's like, I just read the chat, low hemoglobin. So there's not many reasons for a 17-year-old male to have a low hemoglobin, especially when his MCV is normal. So he's not like he's iron deficient for whatever reason. And does anyone want to shout out, I guess, and someone who presents with a stroke, who's severely thrombocytopenic and anemic, is any differential, and again, this is sort of stuff that I probably wouldn't expect a resident to know, but there's any differential that might jump out at them that they would be concerned about and that they would call haematology that night? Antiphospholipids, yes, it could be antiphospholipid syndrome, but I'm thinking of something a little bit more classic.
HUS.
Yeah. Oh, yes. Yeah. That's excellent. So this isn't HUS, but this is HUS is a very, very good differential. So HUS, and the reason I say this isn't HUS, and I don't want to sort of deviate too much, especially with only 5 minutes left, but HUS, this is probably going to be TTP, which is another MAHA. And just for your guys' interest, HUS and TTP both present with the same sort of thrombocytopenia and anemia, and they both have fragments on the film. The way you can kind of tell them apart is that with HUS, they tend to have a really bad kidney injury, or his kidneys are pretty normal. Whereas in TTP, the kidneys tend to be normal and their platelets tend to be a little bit lower. So HUS platelets may be 30 to 40, although there's nothing definitive. But the fact that his kidneys are completely normal makes me think more TTP. And this is just a blood film, I guess, just showing all the fragments and the complete absence of platelets, except for this one little guy here. So if you ever see anemia, thrombocytopenia, well, AKI, confusion or fever, think TTP and call haematology, or think MAHA and call haematology. So very quickly, 90% die if they don't get treated, so that's very bad. Clotting should be normal. Never transfuse platelets if you think it's TTP. It's normally autoimmune in nature, so it's an antibody against this Adams TS13. Adams TS13 normally goes along and chomps up von Willebrand factor. So von Willebrand factor sort of floats along in the bloodstream. Without Adams 13, you get these giant sort of von Willebrands floating through the bloodstream, collecting all the platelets and just wreaking havoc. There's a rare congenital form, which is a bit of a trivia question. I've only ever seen one patient with it, Upshaw-Schulman syndrome. Management is plasma exchange or immunosuppression with steroids. Rituximab can be added a bit later. And there's this special drug that we can never get access to, but can work if it comes back again. So very quickly, just flying through. So cytokine release syndrome is one of the causes of fever with these new drugs. So it tends to be associated with CAR T therapy or bispecific T cell engagers, which are two new immune therapies that we use for lymphomas. Just to quickly answer the question in the chat, transfusing platelets in these patients is just providing fuel to the fire. So the reason they're getting all these problems is because the von Willebrand factor is circulating and binding all these platelets. So you're not going to improve the platelet count because it's just going to be sucked up by the von Willebrand factor, and you may even contribute to making the situation worse. So with CRS, so often they'll have fever, hypertension, tachycardia. It can quickly be life-threatening. The reason these drugs obviously utilize the immune system to attack the cancer, but by activating the immune system, you get all the side effects of an active immune system. So these things here. So you call the heme registrar ASAP. Management will be dependent on the driver. So the management for CRS is different between bispecific and CAR-T. But most of the time it's either tocilizumab or steroids. And you're very cautious in giving them fluid because the fluid, given the risk of capillary leak syndrome, which is just a fancy way for saying that the fluid leaks out of the capillaries into the surrounding tissue, so it doesn't stay in the veins, and it can often leak into the lungs. Engraftment syndrome is a sort of disorder that can occur after stem cell transplant. Tends to occur 12 to 14 days. It's just the neutrophil and the stem cells engrafting into the bone marrow. Tends to present with fever, skin rash, pulmonary edema. Treatment is just steroids. It can be fatal, although that's very rare. I've never heard of it. But we often treat with steroids if that's the case. Hyperviscosity is just a group of symptoms triggered by an increase in viscosity of blood, so the blood just becomes thicker, and that can lead to bleeding from mucosal membranes, retinopathy, neurological symptoms, leukostasis, and the causes are basically any hematological disorder that makes the blood thicker, and the management obviously is treating the underlying disorder. Last question, I promise. Does anyone want to hazard a guess why Waldenstrom's, which is an IgM-powered protein, is at high risk of hyperviscosity? And this is sort of a basic immunology question, rather than a hematology question. Yeah, that's right, Chris. So it's the IgM is physically larger, so it makes it more viscous. Finally, is bleeding on anticoagulants, and I might leave these. You can read these slides yourself, but it's basically just the reversal agents. Often, hematology will be called about this when patients are bleeding on these drugs, and the drugs have specific antidotes for each one. I will just mention that this last point is incorrect. As of a few weeks ago, we now have access to adenosine alpha at the Royal Melbourne. So that's not strictly true, the no reversal agent in Australia. And thanks, everyone. I think that's my hour.
Perfect. Thanks so much, Dr. Harrop, for the presentation on hematological emergencies. I think that was all extremely valuable to all of us, and I feel myself a lot more confident with like conditions like tumor lysis syndrome, febrile neutropenia, DIC differentiation syndrome. So I hope the audience feels more confident approaching these either in like exam or multi-choice setting, or to impress their doctors on ward rounds who maybe don't expect med students to have such in-depth knowledge on these important hematological topics. I'd like to open up to several minute Q&A if anyone has any final burning questions to Dr. Harrop about anything that he's mentioned in the webinar, or potentially about a career in hematology, the pathway. I'll keep the floor open for a few minutes, and then after that, I'll do a quick spin the wheel to decide who will be the winner of the $25 gift vouchers. And if you'll be able to unmute yourself to ask the question, that could be great as well.
Yeah, I had a question. At the start of your talk, Dr. Sean, you mentioned something about the lab trainees doing 2 years in the lab, but then maybe some people do 3. Is that what you said?
No. So hematology training, at least in Victoria, is you do 1 year of internship, and then you do 3 years of basic physician training. In your 3rd year of basic physician training, you will apply for a speciality. So if you decide to do haematology, you'll enter into the, you'll do your first year as a clinical haematology registrar. So that would be your first advanced training year. And then at that point, you would either decide after that year to do laboratory training, which would be 2 consecutive years. And then after your 2 consecutive years of lab training, in your second year of lab training, you would have more exams after your BPT exam. So this is laboratory exams. You would finish that lab year, and then you would have a final clinical year, and then you're done. Some people nowadays are entering clinical haematology as a first year AT and then deciding that they just want to do clinical only. They don't want a laboratory qualification or pathology qualification. And then they just go on to do 2 more clinical years after that first AT year. They still end up doing, you still have to do 6 months in a laboratory. So you don't do no lab training at all. But you don't get that, you don't have to sit the exams, but you don't get that secondary qualification. So you're not a dual qualified pathologist physician. You'll just be a physician. Does that answer?
Yeah. So it's 4 years in total. So it'd be 2 years.
Four years for dual training, 3 years for single pathway.
Great. Thanks for the question, Holly. And we'll take one more final question if anyone has anything they'd like to ask.
Yeah, thank you so much for the talk. I thought I may as well just ask, I guess as a medical student, I feel like we don't get a lot of teaching in this, as was alluded to before. I was wondering if you knew of any good resources, podcasts, anything that would be good for our level to help learn this stuff, I guess, before going into, residency years.
Yeah. I agree. I think there's a sort of a deficiency in haematology in most medical school curriculums. And I'm not quite sure why. I suspect it because haematology is very sort of subspecialized. Like a lot of it is really cutting edge. So the drugs we use today were only in clinical trials a few years ago. So it's sort of very hard to write a curriculum around that. It's kind of like oncology in a way, I guess. But basic hematology, like your platelets and your red cells and your white cells, should all be, I think, should be probably better covered. I think transfusion medicine as well, even though I'm not that excited by it personally, I think it's an area that all physicians should, or surgeons and surgeons as well, should be comfortable with, and that's sort of unfortunately not taught as well as it should be. Or sorry, not as well, but as much as it should be. But I understand that the schools have a really sort of intense curriculum that they've got to sort of cram as much stuff into as possible. In terms of textbooks for hematology, the problem is a lot of the books get out of date quite quickly. And I guess a good introduction book for, I guess, the general hematologist would be what aspect of hematology would you, I guess, would it be sort of more the pathology side or the treatment side, or just anything?
Yeah, I reckon a bit of everything. Probably a bit more clinical than pathology.
Yeah. So Barbara Bain, Bain, Barbara does a lot of the pathology books. So she's actually from Queensland, and she does quite a good pathology approach. In terms of clinical textbooks, like I said, they go out of date so quickly. Hoffman has got a book, but it's not really sort of a easy approach kind of way. It's just sort of lists all the facts, and a lot of them become out of date. So in terms of learning the diseases and the disorders, unfortunately, there's no sort of ideal resource. It's really just piecing it together from places like the WHO Blue Book, which is sort of the Bible of hematological disease, and then obviously research papers. So sort of Blood Journal and the British Journal of Haematology would be the two journals that I would sort of personally read the most. So I probably didn't help that that much, but I guess it highlights the lack of sort of introductory hematology text in for medical students.
Yeah, that's all good. Thank you.
Okay, thanks so much everyone for your questions, and Dr. Harrop for going through them in depth. I'll quickly do a spin the wheel before we wrap things up for today. So just to confirm, can somebody just yell out if they can see the wheel here?
Yeah.
Great, thanks. Okay, so for our first winner of the $25 gift voucher, we are going to have Kevin. Now, some people have left the call, so they won't be eligible if their name is called out. But Kevin, if you're in the chat, can you please message me your student email address so that we can get in touch? If he's not, then it will be respun.
Yeah, hi. Yeah, I'll message you.
Yeah, great. Thank you. And then for the second winner, Madison, congratulations.
Thank you.
I think this is a good karma for asking your question. So just send me a message as well with your email address over Zoom, please.
All right, will do. Thank you.
Okay, if you guys could just put it together one more time for Dr. Harrop for generously giving his time for that really interesting webinar and looking after us with all his advice and questions, that would be really great. And if Dr. Harrop, you could, and the education subcommittee, if you could stay back for just a couple of minutes after everyone leaves, that would be great as well. Thanks so much, everyone. Okay. Well, thanks again, Dr. Harrop. That was a really great webinar. How did you feel that went? Is there any feedback that you can give in terms of what for future webinars that we run, we could potentially do differently or change around?
No, that was fine, Phil. Sorry for the IT issue. I think my headphones died and I had to switch.
Yeah, no stress at all. That's all good. Yeah, well, we'd also just like to send you a little token of our appreciation with a voucher. So I'll just send that through to your email address when I next get in contact with you. And we were also going to run a careers night sometime later on in this year, where we were hoping to gather a panel of experienced hematologists to tell us a bit about their career journey and choices that they made that as future junior doctors that we are going to need to make if we want to pursue hematology. So not something that we need to organize now, but just wanted to raise it and see if you could potentially be keen for an evening to join the panel with some other hematologists that we're trying to organize. Oh, are you able to hear us, Dr. Harrop? Yeah, no worries. He's just messaged that his mic has dropped out. That's all good. Yeah, no worries. I'll probably just get in touch a little bit later on then. Well, thanks again, Dr. Harrop, and thanks again to the education subcom team and the rest of the Haematology Society for help organize and run the event. Thanks, guys, for coming. And yeah, have a good night, everyone.
Thanks, Phil.
Thanks for running the webinar. Philip.
All good, guys. Hopefully you enjoyed it.
Yeah, thank you, Phil, for running that.
All good, all good. All right, see you guys. Have a good night. Bye.
Great job, Phil.
Thanks, Phil.